I'd like to thank Dr. Raju and his team for giving me this opportunity. I never go back from a good debate. That's been my mantra from my training days, and we trained together. So Raju must have remembered it. And he's given me a little bit of a one-sided debate. We'll see. So today we are going to debate about whether coronary angiogram is a must for patients undergoing renal transplant as a pre-transplant workup. Thanks to my organizers who have given me very short time, I'm just going to take a nail and hit the target with a hammer and not go over a lot of evidence or break into the topic. So my questions are only two. Do we need to evaluate for cardiac disease? And if so, why should we do a coronary angiogram? I'm convinced we have to do a coronary angiogram, so I'm going to present evidence for that. So why evaluate? All of us know that dialysis patients come with a very high burden of coronary artery disease. Almost 50% of them are asymptomatic, or if they have symptoms, it is difficult to differentiate between CKD symptoms and cardiac symptoms, like volume overload, gastritis, those things mask as cardiac symptoms. Peri-transplant, the cardiovascular risk is increased. If you look at this original paper, the Wolf paper, this is the famous paper which showed that transplant is associated with better survival than dialysis. If you see that, only after 8 months, you get a survival benefit from transplant. Before that, even after transplant, survival is up to 3 months, it's worse than dialysis, and after between 3 to 8 months, it's about catching up. Only after 8 months, you see the survival advantage. Why is that so? Because of the high incidence of peri-transplant coronary events. So if you look at the cardiovascular death rates, it is highest in the first 3 months. So we need to worry about peri-transplant cardiovascular risk. So we are offering a treatment which is so expensive, and some live person is donating an organ. In our country, most of the transplants is live related, not disease donor. So taking out a kidney from a normal person and putting it in another person and losing the person with a functioning graft is not a good thing to do. And not only early post-transplant, in late post-transplant also, death with functioning graft, the commonest cause is cardiovascular disease in the West, and in India also it is the second commonest cause. Again, if you look at this data, this is one of the old papers from BHU. So they looked at 100 patients who got transplanted in their center and for whom they had follow-up. Look at this, the young patients, young recipients, very few having diabetes. This used to be the practice when I started training. Diabetics were rarely transplanted because of the concern of cardiovascular disease. So if you look at that group also, look at the cause for death with functioning graft after sepsis, it is coronary disease and cerebrovascular disease, together about 36%. So even in India, not only this paper, there are other papers like this one, this particular one I really like. This is from the Toronto group, St. Mike's group. They looked at cardiac events post-transplant based on the ethnicity. And they found South Asians, meaning Indians, Pakistanis, Bangladeshi, and Sri Lankans. That's all. These 4 countries comes as South Asians. And they found that South Asians have 4.4 times high cardiac events compared to 1.16 per 100 patient years in other ethnic groups, including blacks. South Asians did the worst. This is important because they had 135 patients, South Asian patients, and it's one of the well-done studies. And this one is a paper from Gangaram. Again, just to reiterate, this was looking at some other outcomes. They were looking at survival in elderly patients after transplant. But they had data on all the patients, 1,000 plus patients. Again, the commonest cause of death with functioning graft after sepsis was cardiovascular disease. So we cannot discount cardiovascular disease even in India. It is the second commonest cause. Organs are a scarce resource. Today in Tamil Nadu, there are 6,000 plus patients waiting for transplant. Okay, the transplant waiting list moves not because we have allotted organs to the patients. Most of the time patients die on the waiting list. And that's how the transplant list moves. Things are changing now, but this is the current scenario. And the most important thing is this conforms to principles of screening as defined by WHO. There should be a significant burden of the disease. There should be an asymptomatic phase where we can test, and there should be some screening method which can be used. There should be an intervention, and then the intervention should improve survival. That last part is the one which we are going to discuss in this debate. The rest of it, it conforms very easily. So it is asymptomatic in CKD patients. We can screen them with multiple tests, and can we change their outcome is what we are going to discuss. So screening is required, that's we have understood. So why screen with a coronary angiogram is the second question I want to answer. See, what are the other options we have? We have risk scores. They do very poorly in our CKD patients because CKD patients do not have the traditional risk factors alone. They have other risk factors for atherosclerotic burden. Second thing is, you can do a myocardial perfusion scan, you can do a stress echo, and you can do a CT angio. That is CT coronary angio, non-invasive. So how do these tests perform? Let's first look at the myocardial perfusion scans, MPS. So most of these tests are plagued by very low sensitivity and specificity. That's the bottom line. So the sensitivity and specificity is low. So what it means is, suppose you have a patient with severe ischemia in the stress test, in the MPS test. Their coronaries are normal in up to 26% of these patients. And if they have mild ischemia in the MPS test, still 20% of them have multivessel disease. What are we differentiating? Whom are we identifying by these scans? One thing we do know is, if you have severe ischemia in the MPS scan, it is associated with increased death, increased cardiovascular death. Many of these patients do get revascularization done. But more importantly, patients who are negative in these tests are more likely to be transplanted. This is something you should look at. So, this is important because when we look at the outcomes, a lot of these patients who are low risk are getting transplanted. So they have the benefit of the transplant. So you don't see the benefit of the coronary revascularization. I'll talk about it in the next slides. Then coming to stress echo, again same issue. The sensitivity and specificity is low. Same problem. In patients with low risk and high risk, it doesn't really help in differentiating. If you have high pretest probability of having a coronary artery disease based on risk factors, and if your stress echo is negative, you still have a chance up to 70% that you can have a coronary artery disease, which is being missed by this test. If your pretest probability is low and you have a positive result in the stress test, there is a high chance of up to 58% that you don't have a disease, and this is picking it up. So, but again, the stress echo helps in identifying patients who are at risk for cardiovascular events. So they identify patients at risk, but they are not good in telling who has it or who does not have it. So I would not consider them as good screening tests. What about coronary CT angio? See, this provides anatomical information rather than functional information. And there is limited radiologist experience. Not all radiologists can report on CT coronary angio. Not everyone who reports CT. And it can cause false positive due to coronary calcification. The sensitivity is very high, 93%, but specificity is low, which means you will get a high false positive rate of 29%. So there are some groups which are looking at doing a CT coronary angio. If you find it positive, then to avoid the false positives, then you go ahead and do a perfusion scan, and then you weed out all these false positives, and then think about an invasive coronary angio. So my point is, all these screening tests are not relevant. We know there is a burden of disease. So what are we left with? Coronary angiogram is the only option we are left with. Coronary angiogram can be therapeutic in addition to diagnostic. You can, at the same time, you can intervene and revascularize. Usually we used to think it is only an anatomical test. No, but with FFR availability, we can get functional information also. It gives the information on the reserve for the flow. And there are a couple of centers, single centers, where they did direct coronary angio in patients with certain risk criteria, predominantly diabetes, number of years on dialysis, and the age criteria. That was the biggest criteria, but they had multiple other criteria. When they did directly coronary angio, no screening test, they found 20 to 50% of them had significant coronary artery disease, and half of them were negative by stress test. That is, the stress test was done by someone else, but when they come to their center, they directly did an angio. So now that we know angio is the best screening test, what I have to prove is doing an angio and then an intervention will help the patients, then we can say angio is indicated. So earlier, even during my training days, cardiologists would say CKD patients don't do well. They would not be interested in doing a PCI at all in CKD patients. That's not true. This is data from Canada again, basically registry data where they took patients who underwent angiogram, followed them up to see if they got revascularized or not, and then looked at their outcome. What did they find? The panel B, if you see, that is non-dialysis CKD patients, and panel C is dialysis CKD patients. In both the groups, revascularization was associated with better survival compared to no revascularization, albeit lower than normal population. But we are not trying to compare with normal population. We want to improve our patient survival. But remember, this is not patients who were screened, like not all patients who came in, then they did an angio. What they did is, they just took the registry data of whoever underwent angio. So who underwent angio, who selected that, we don't know. What was the criteria for taking them for angio. And there are multiple retrospective trials like this. I've just put up a meta-analysis which showed 17 trials. All of them have shown, this meta-analysis also has shown, there is a survival benefit in revascularization. So once you do a coronary angio, if you find a significant disease, revascularization helps. It improves survival. So what about, the point now is, my learned friend is going to say, who did you take for angio? Maybe you took only the high-risk patients, you didn't take the low-risk patients, and that kind of argument. So that does matter. It's not like everyone who went for transplant got an angio and then they revascularized and the outcome was better. He's definitely going to show you data otherwise. But ideal answer to this question would be, you do a randomized control trial of all patients who are waitlisted for transplant, and then you have predefined criteria, put them all through angiogram, and then revascularize and see what is the outcome. There's only one trial like that from 1992, and 1992, all insulin requiring diabetic patients, they did coronary angio straight away. Out of these coronary angio, 21% of those patients had significant vascular disease. That is 31 patients. Among these, 26 patients agreed to randomization. So they randomized them to receive either medical treatment or revascularization. And the composite primary outcome was worse with medical management compared to revascularization. Okay? Sorry, it should be opposite. Medical treatment group, 77% had primary outcome, and revascularization group, only 15% had the primary outcome. So what is the HALA all about? So there are good data. So this is the reason for all the confusion. So recently there was an ischemia CKD trial on advanced CKD patients and patients on dialysis also. Some of them were on dialysis. And they showed that patients who underwent angio, I mean they randomized them to get either invasive strategy, that is angio and intervention, or just medical management. And the main study, ischemia CKD trial, there were 777 patients, and over a period of 3 years, they didn't find any difference. But this is a subgroup analysis. Among the 777 patients, 194 patients were on dialysis waiting for a transplant. In these patients also, there was no difference in the primary outcome. That is, there was no difference in death or non-fatal MI post-transplant, whether you did invasive treatment or medical management. But the entry criteria for this study was flawed. It was based on patients getting screened by those flawed tests. Either most of them got myocardial perfusion scan. If they showed moderate to severe ischemia, then they were randomized to get either a coronary angio or not. We have already clearly established myocardial perfusion scan does not clearly discriminate between patients who have significant coronary artery disease or not. So they started off with a wrong point, and the other problem is, a lot of these patients, even in the control arm, the ones who are on medical management, ended up having intervention. Up to 20%, this is in the main ischemia CKD group. It was similar in the subgroup analysis also. In the intervention group also, only 50% of them ended up having intervention. Mainly because a lot of these patients didn't have significant narrowing in the angiogram. So it didn't pick up. The testing did not pick up the right candidates. And in the medical management group, again 20% got intervention. So study population was asymptomatic patients who were subjected to this. They excluded patients with reduced ejection fraction, recent ACS, heart failure. So they just took very stable patients who may or may not require any intervention in the first place. And overall, the study is criticized for very low adverse events compared to what we see in the normal population. So where does it leave us? With a lot of gray areas. What are the gray areas? We don't, the actual truth is, we don't have a good randomized control trial to answer our question for today. Transplantation itself will act as a revascularization. This is important. See, you get a survival benefit with a transplant. So patients who get angiogram or revascularization, there is a delay in getting transplant because they are on double antiplatelet therapy and then you cannot transplant them for the first 6 months. So maybe there is no survival benefit after a revascularization because their transplant is getting delayed. So some of the difference might be because of that. And transplantation would modify a lot of the risk factors for inflammation, atherosclerosis in our patients. And what about living down a transplant? That is our bread and butter. We don't do that many disease donor. So all these is for patients. Most of these trials, if you look at it, when they say high risk, they mean patients who are waitlisted for more than 2 years, on dialysis for 5 years, that kind of story. So that's not what we normally see. We do not know the answer. We don't have any data from India. So what is important is to balance between optimizing coronary care, but we should avoid delay, and that's something we should be looking at, not to say don't do coronary angio. What do the guidelines say after all this? The guideline is more confused. Or the people who are writing the guidelines are confused, obviously so, because we don't have much data. All that it says is you should screen candidates, okay? And you should not exclude patients with asymptomatic coronary artery disease. And finally they say, we are eagerly waiting for contemporary evidence and to look for the utility of coronary revascularization in asymptomatic coronary artery disease. So the honest truth is we don't have evidence. So what should we be doing, or what are we doing? The Indian data which I showed earlier, the IKDRC group, they very clearly mention all their diabetics get coronary angio straight away. Then this, the Gangaram paper, all the elderlies got angio straight away. So the standard of care as of now is everyone gets an angio. What about, this is very patchy, it may not be true for all the centers. So this is from the UK, where they screened all the centers. And what did they find? Screening pattern was very variable. There were centers which were screening only 10% of their patients, and there were centers which were screening 100% of their patients. And how did they go by? They went by the usual traditional risk factors. And what tests did they do? Again, the flawed perfusion scans and the stress echoes. And so no one knows what should be doing. So what should we be doing? This is one of the saner voice. This is Cheng et al., recently published in 22. Just one more minute, please. And what did they find? What their suggestion is, if you think there is a high suggestion of coronary artery disease, if there is low EF, there is regional wall motion abnormality, please directly go ahead and do an angio and do a risk stratification and do a revascularization. If they are absolutely low risk, they have not been on dialysis for long, they are young people, no risk factors at all, don't do anything. What do we do if they are falling between the two criteria? Again, they recommended this, but at least they have reduced the gray area to patients with intermediate risk. So what do I suggest? I suggest coronary angio is definitely a must in high-risk group. No other test will give the information we need. It is diagnostic and therapeutic and helps in risk stratification. In the intermediate risk, as of now, because there are no better screening tests, maybe coronary angio should be done. And actually my friend also agreed. In his center, if he is in doubt, he doesn't do MPS, he directly does angio. So that's me and Ranjit debating. I would just like to remind the chairs, please remember what happened after the voting of the debate and don't do the mistake again. Thank you.
Thank you.